Hello, everyone, and welcome to our session entitled Orchestration of Heart Failure Management Beyond Optimal Medical Therapy. We are incredibly honored to have with us today such great speakers from different parts of the world. And please let me introduce my co-chair for this session, Markus Wollner, who is a consultant for cardiology at the Medical University of Graz, Austria, and adjunct professor at the Temple University in Philadelphia, and another co-chair who is a very good friend of mine and my colleague, Yuri Mariev, who is cardiologist at the National Medical Research Center for Therapy and Preventive Medicine, Moscow, and researcher at the Robinson Center of Biostatistics, Glasgow, UK. Yuri, please start your talk.
Yes, thank you. My talk will be medical therapy for targets and other pathways. Here's my conflict of interest. So when we're speaking about treatment to have PrEP, we're speaking about four types of therapies: Sglt2 or ACE inhibitors, dapagliflozin or empagliflozin, beta blockers, or aldosterone antagonists. However, in some patients, we need to use additional therapy, and it's very important to tailor this therapy to personalized treatment dependence of needs of our patient. For example, we need to use loop diuretics or thiazide diuretics in congestion, and there was a great session before about congestion. We should use anticoagulants in patients with atrial fibrillation. Moreover, in some patients we should refer to atrial fibrillation and ablation, or if we choose rate control, in some patients we should add digitalis. Also, a patient with sinus-treated left bundle branch block and wide coarse, we should refer to CUT. In patients with sinus rate and heart rate on beta blockers more than 70, we can add ivermectin to additional improve prognosis. In patients with iron deficiency, we can use additional terracoscopic controls. And in black and self-defined black patients, and also in some other situations, we can use additional hydrolysine nitrates. And we can use mitral edge repair in patients with mitral regurgitation. And in advanced disease patients, we can use in some situations digitalis, vertigoats, and of course, if it's not possible, or if and everything not work, we can refer patient to heart transplantation. And in my talk, I will speak about some of these options. Why we're speaking about iron deficiency in heart failure? Because 60% of ambulatory and 85% of hospitalized patients with heart failure has iron deficiency. Iron deficiency reduces quality of life and increases risk of heart failure hospitalization. And at the same time, iron out trial shows that oral iron doesn't work in patients with heart failure. At the same time, we have several studies and PAIR-HF among them that iron intravenous iron improve quality of life and 6 minutes walk test in patients with heart failure. Also, we have a PAIR-HF study in patients with stabilized after heart failure, decompensation of heart failure, and this study shows nominal reduction in number of total heart failure hospitalization and cardiovascular deaths. However, as you can see, the p-value is above standard line. It's 0.06. However, this study, all of us are heavily deterred by the COVID-19 pandemic, and during pandemic, patients less go to hospitals, sometimes for bad reasons because they're afraid to go in the hospital, but sometimes for good reasons because they stay at home, use more food which they cook themselves, and they use less salt. And this is why it's quite interesting to look to pre-COVID analysis, which shows that there is a reduction of composite endpoint. Moreover, if we look total hospitalization for heart failure, even with analysis during COVID pandemic, it shows that there is a reduction in total heart failure hospitalizations. So in the ESA guidelines, it said that it's recommended that all patients with heart failure be periodically screened for anemia and iron deficiency with full blood count, serum ferritin, and serum ferritin concentration and SAT. And we should think about using ferrocarboxy method in two situations: symptomatic patient with left ejection fraction less than 45 and iron deficiency to elevate heart failure symptoms, improve capacity and quality of life, and also symptomatic heart failure patient recently hospitalized for heart failure with left ejection fraction less than 50 and iron deficiency to reduce the risk of heart failure hospitalization. The second part of my talk will be about patients with HAPREP, sinus rate, and heart rate more than 70. We know that there is a lot of data that in patients with beta blockers, heart rate more in sinus rate, heart rate more than 70 associated with bad prognosis. And we had a therapy to improve this prognosis. SHIFT trial show in patients with heart failure with left ejection fraction less than 35 sinus rate and heart rate more than 70 using ivabradine reduce composite reported cardiovascular death or heart failure hospitalization by 18%. Moreover, in patients who didn't take beta blockers because, for example, there is contraindication, there were also reduction in all-cause mortality. So, in the guidelines, both in Russian and ESA guidance said that ivabradine should be considered symptomatic patient with left ejection fraction less than 25 in sinus rate and resting heart rate more than 70, despite treatment with evidence-based beta blockers and other optimal medical therapy. And moreover, we can thinking about ivabradine in symptomatic patient also with left ejection fraction less than 35 in sinus rate and heart rate more than 70 who are unable to tolerate or have contraindication to beta blockers. But I should say that European Medicine Agency approved ivabradine for use in Europe in patients with HAPREP with with heart rate less than with heart rate more than 75. So we can discuss the moment when we should start this drug, but it certainly can improve prognosis of some of our patients. The third part of my talk will be about digitalis. There is a recent joke about the type of heart failure articles. And one of the popular articles is articles, there's a lot of them, then digitalis help or harm some of patients. But we should remember that this is observation works, and this work didn't show what was the reason for prescription, but at the same time, digitalis is usually used for advanced heart failure or heart failure with rapid atrial fibrillation despite beta blockers, and these patients differ from other patients who will not use digitalis. So, and we should remember that harm due to digitalis was shown in observational works without count difference between groups, and it's not seen in many works with propensity matching, which compare groups like decent, and moreover in randomized controlled trials. So in the guidance it said digoxin may be considered in patients with symptomatic HAPREP and sinus rate despite treatment with ICA inhibitors or trilosartan, beta blockers, and other testosterone antagonists to reduce risk of hospitalization. This is based on quite old study, DIC, when we not use all of our therapies, so the class of indication is low, and we certainly need new studies in cardiac glycosides. But probably we need more data, but as some analysis of DIC trial show, we can have a dramatic reduction in combined endpoint heart failure hospitalization or heart failure mortality in patients with left ejection fraction less than 25 and in patients with New York classification class 3 and 4. Moreover, we can thinking about digoxin in patients with heart failure and atrial fibrillation in two situations: when heart rate is too high despite beta blockers, and when we can't use beta blockers. So in this situation, we can think about digitalis. Of course, when we're using digitalis, we should remember about narrow therapeutic windows. So levels should be checked, aiming for serum digitalis concentration less than 1 and 1.2. And caution should be also be exerted when used in females, the elderly, frail, hypokalemic, and malnourished subjects. So in Russian guidance, it says that it's better to check the concentration, and if it's impossible, use low dose. And moreover, to remember to reduce more this dose in females, elderly, in weight less than 60 kilograms, and in patients with glomerular filtration rate less than 60, but we still can use this drug in this patient. The last part of my talk is about Versigluat. It's a new drug, and it is in the ESA guidelines. It says that we may consider in patients with neuroplastication class 2 and from 2 to 4 who have worsened HFA despite treatment with optimal medical therapy to reduce the risk of combined emporium, CV mortality, or failure hospitalization. This is based on Victoria trial, which is the modern trial, which shows that upon all new medical therapy using versugalis in such patients reduce the number of combined endpoints. Moreover, as they take patients with high-risk patients, there was a decent absolute reduction of risk, and number needed to treat is just 24 patients. So I want, in the end, I want to say for some future direction, of course, we need pragmatic studies on the order of adding disease-modified drugs for HFrEFs, both wonderful for how we should use them, and both, of course, additional therapy. We need new studies with digitalis or other cardioglycosides in patients with sinus leads, and this study is ongoing. We need pragmatic studies in best order of rate control medication in patients with atrial fibrillation. And we need to evaluate the role of new drug mecarbine in patients with HFrEF. This drug is not have not been in the guidelines yet, but it could be really, it probably could help some severe patients with low ejection fraction. And we definitely need new studies with our medication in heart failure, both HFrEF and HFrEF. And very important, we need new study in patients with blood pressure less than 100, because we have a lot of new great therapies in patients with blood pressure more than 100, but we have less new data about patients with blood pressure less than 100, but still this patient usually have high risk, and we really need new data to improve prognosis of these patients. Okay.
Thank you very much.
branch block, large QRSs. But I want to focus your attention. So Yuri, just before, was very kind and talked about digoxin. And I'm going to talk the one next to it, PVI, which is pulmonary vein isolation, which is the basis of AF ablation. So I consider it to be a bit hidden away in the guidelines, and I'm going to make my case. So let's see where this comes from. The first trial was the ATAC trial, published in 2016 from the teams by Luigi Di Biase and Andrea Natale, where they compared catheter ablation, so AF ablation, versus amiodarone in patients with heart failure with a reduced ejection fraction. They used a threshold of 40%. And their main primary outcome was AF-free survival, and they looked at several secondary endpoints such as death, hospitalization, and so on. Just a quick look at their patient cohort. So a median age of around 62. The AF was ongoing for around 8 or 9 months, ejection fraction around 30. And remember, these were all patients with continuous AF monitoring with their devices. So they randomized patients to catheter ablation and amiodarone. They followed them for around 2 years. Their main finding was that after 1 or 2 procedures of catheter ablation, the percentage of arrhythmia-free survival was significantly higher in the intervention arm compared to amiodarone. But more interestingly, they stumbled upon a reduction in unplanned hospitalization, and even more important, a reduction in death with a number needed to treat of 10. So, of course, there were criticisms to this trial. It was not designed to assess clinical outcomes. The primary endpoint, once again, was AF-free survival, and their control arm was only amiodarone. So there was this question whether does the AF ablation lower the mortality, or does the control arm, amiodarone, increase the mortality and make AF ablation seem better in that context? Then came Castle-AF, 2018, the New England Journal of Medicine, Nasir Marrouche and Johannes Bachmann. So they asked the question, does AF ablation improve outcomes in heart failure patients more than medical treatment? And this time, the primary outcome was death or hospitalization for worsening heart failure, and as well as several other secondary endpoints. Now, their study population, so they looked at 3,000 patients. They only randomized almost 400, randomized to AF ablation and medical therapy. Their main inclusion criteria was heart failure with a reduced ejection fraction of 35% this time, symptomatic AF, what they called an absence of response to, unacceptable side effects from, or unwillingness to take antiarrhythmic drugs, so amiodarone, and interestingly, a Biotronic device, so either ICD or CRTD, well, because Biotronic was the funded the trial. So they followed these patients for about 3 years. Again, just a quick look. So median age 64. Most were in New York Heart Association class 2. A good mix of ischemic and non-ischemic cause of heart failure. Mostly persistent AF, almost all of them persistent AF patients. The ejection fraction was around 32%, and almost half of them had amiodarone failure, some of them unacceptable side effects, and 40% never used. The medical therapy arm, this time, so around 70% of them were in rate control, so less rhythm control, which was one of the criticisms to the ATAC trial. And what they found was that, so their primary outcome was a reduction of almost 40%, so death and hospitalization for heart failure, and each of their components was significant. So they found almost 50% reduction in death from any cause, death from cardiovascular death, of course, and heart failure hospitalizations. They had a number need to treat for the primary outcome of 3 years of 6 patients. These are the Kaplan-Meier curves for their results for the primary endpoint and from death from any cause. Interestingly, the curves start diverging around 3 years. I think this is up for debate, and this is a good discussion question. Why did this happen? They saw an improvement in left ventricular ejection fraction already at 1 year, and then stable at around 5 years. There was a lot more maintenance of sinus rhythm in the ablation arm compared to the drug therapy arm, and more interestingly, more importantly, so because these patients all had devices, they could measure the AF burden, and we can see a significant decrease in AF burden with catheter ablation in these patients. So Castle-AF had some limitations, of course. So there was this question of patient selection, only 10% of all those eligible. And they also had quite a few crossovers. So 15% were supposed to have the ablation, but did not have the procedure. And 10% were supposed to be in the drug treatment arm. But however, they did get an ablation during the trial. We will discuss these a bit later on. And I really don't know what to say about this. There were more patients lost to follow-up in the ablation group. Is it random chance? Is it something else? I don't know. I'm curious about others' opinions. So coming back to the ESC heart failure guidelines, They do look at CASTLE-AF, but they see that they consider the role the highly selected population, was not blinded, had crossovers between the two treatment strategies, and the events were low. So their conclusion is that catheter ablation versus medical treatment showed a consistent improvement in symptoms, whereas the results of mortality and hospitalization were obtained with a relatively small number of events, not permitting to draw definitive conclusions. So let's take their arguments one by one. Highly selected. So it's true only 10% of all eligible patients were randomized, were included, but let's see why. This is the information of why the patients were not randomized, so either not fulfilling inclusion criteria or violating at least one exclusion criteria. And I would like to point out that almost a third, so 1,000 patients, were refused because they had a device from a different vendor, so either a Medtronic device or Boston Scientific device or whatever. I don't think this is a legitimate reason to exclude patients. AF not being symptomatic in 10%, I think this can be discussed. And of course, some of the patients were so severe that they were already listed for heart transplant. That the trial was not blinded. Well, it was not, but, and I'm a big fan of blinding trials and placebo controls and sham controls, and shout out to the Orbit team for their work on PCI. But here, the endpoint in question was all-cause mortality. I have trouble seeing how a blinded trial could make a big difference in this regard. Furthermore, the guidelines accept CRT as a class 1 indication, although the CARE-HF trial, which established the mortality benefit, was not blinded either. Crossover between the two strategies. So the 15%, 10%, we already discussed this, but importantly, the analysis was an intention to treat analysis. And usually in these circumstances, crossovers bias towards the null. And in this case, we saw a huge improvement in mortality, we can say, despite the crossovers. The number of events was low. This is true, but there was enough to prove a statistically significant result. It was what the trial was powered for, what they had estimated before, and it was what they found and what they proven statistically with a number needed to treat of 6 patients. I don't think bigger trials are necessarily better. I think they are needed to parse out small effect sizes, and in this case, it was a big effect size. So the guidelines finally state that in cases of clear association with paroxysmal and persistent AF and worsening heart failure symptoms, I don't think this was the inclusion criteria of the trials, which persist despite medical treatment. We can argue about this, but it seems to be on top of medical treatment. Catheter ablation should be considered for the prevention of treatment or treatment of AF. I think this could be better worded as catheter ablation should be considered for improvement in mortality. Even the classes there. So class 2 regarding methods, they speak of conflicting evidence, which I'm not exactly sure is the case here. And they quote a level B, level of evidence B, which would be a single randomized control trial or large non-randomized trials. And I think even the guideline authors themselves cite 2 randomized control trials, as we've discussed today. And we haven't even discussed the results from the Cabana trial, the subgroup analysis regarding only patients with low ejection fraction, which confirms this mortality benefit. So I don't want to be naive. I don't want to be. I don't want to build castle in the sky. I don't want to make false idols of any procedure or any treatment. And I do agree with some of the criticisms from Milton Packer, especially with his conclusion that I think we should work together to make sure that future trials are properly designed, performed, and analyzed. However, I don't think it is wrong to consider that AF ablation could have an improvement in mortality. And I'm going to, at least, the very least, the wording should be slightly different, as I've are good. So I'm gonna leave you with another castle in the sky. This is the sunny Monaco, and this is the project of our new hospital here. And I would like to thank you once again for the time.
Thank you. Thank you very much for your talk. It's really interesting. I think we can have a discussion in the end. At this moment, we will go for further presentation. I'm also sorry for some technical problem between presentation. So the next speaker will be Maria Simonenko. She is heart transplant cardiologist at researcher at Cardiopulmonary Exercise State Department of Almazov National Medical Center in St. Petersburg. And her talk will be rehabilitation.
Dear colleagues, thank you for the invitation, and I'm going to highlight the importance of rehabilitation in heart failure patients. So my conflict of interest are that I'm the UPC Secondary Prevention Rehabilitation Section member. So as I always explain to my patients, there are windows, and the first window is for lifestyle management or rehabilitation, and the second one for drug management. Then we are going to surgical treatment, and still we need to use all of them. You can't use only one option like lifestyle or surgical treatment. You need to use all of them for patients. So cardiac rehabilitation programs, and it's recommended that patients with heart failure are enrolled in comprehensive cardiac rehabilitation programs to reduce the risk of heart failure restoration and death, especially in long term. According to a recent transitional paper that was published a year ago, there are core components of rehabilitation in chronic heart failure, which are patient assessment, counseling, exercise training, different kind of lifestyle management like diet and weight control management, also medications, lipid management, sports exercise, and psychosocial support. Also, in the recent UCC guidelines for heart failure, finally was added that exercise is recommended for all patients who are able in order to improve exercise capacity and quality of life. It's going to reduce their admission to the hospital. So I want to separate my presentation for heart failure and what's going on for patients who were heart transplanted. First of all, rehabilitation is recommended for all patients with established heart failure, no matter of their level of left ventricular obstruction or whether they bought cardiocompatible electronic devices or MCS, which is only long-term MCS. In all patients, we need to prescribe rehabilitation, not only in the hospital, but while patients are in outpatient department management for the long-term follow-up. So first of all, we are going to the first core component, which is patient assessment, and we need to check patient clinical assessment, their comorbidities, the different kind of complications after the surgery. Also, there are markers of disease severity that we need to check. The functional assessment results of transthoracic cardiography and CPH results. The next level is physical activity counseling, which is always should be regular, and we need to increase it gradually in patients while patients are under supervision. The other parts that weren't established or agreed issues for these patients that we need to not only looking for a personalized approach, but we need to look for a different kind of not only exercise trainings, but different kind of dancing or yoga or tai chi is something try to patients that's going to be benefit for them and can be well accepted. And also the prescription of potentially different kind of unsupervised activity like running or jogging without healthcare specialists needs more evidence and wasn't agreed for today. The next point, I'm not going to stop what kind of exercise training we need to prescribe. But first of all, for heart failure patients, it's about the regular. The next one is going to be how frequent it is, and it should be interval training and exercise that will large muscle groups, and it should be gradually increased. But there are some issues that need more evidence, like their upper limits of exercise training intensity are not clearly defined yet for these patients. And also there is a limited information for combination of different exercise training types. And when we prescribe exercise training for chronic heart failure patients, you need to look for aerobic and resistance exercise for both of the components for patients, and we need to increase the training regimen for them in the few months. Only in the recent guidelines that were published during last 1 or 2 years, finally we can see that not only rehabilitation was added for these patients, but also the exercise-based rehabilitation. And we can see this in American College of Cardiology guidelines that were published this year, and the same we can see in UCC guidelines that were published only a few months ago. Like, as you can see, everywhere we can have exercise rehabilitation for chronic heart failure patients. Part is heart transplantation. I frequently see the misconception from healthcare specialists and patients, like heart transplantation is the end of everything. Like after heart transplantation, after the surgery, patients will going to be fine and don't need any rehabilitation or any drugs or something. You need to understand that heart transplant patients, they are going to be follow-up for the whole of their life. This is lifelong rehabilitation, not only during their admission to the hospital, but in outpatient department also. And we need also to look for a different kind of postoperative issues like physical deconditioning, muscle atrophy, and impact of immunosuppression. And all these factors can limit the physical capacity of transplanted individuals. Next, it should be not only rehabilitation, but especially exercise-based cardiac rehabilitation for lifelong treatment. There are a few points that we need to check for every heart transplant patient. There are all embolization from hospital admission after heart transplantation for the whole day follow-up. Then it should be combined, and we look always for personalized approach for every patient. We need to increase it gradually, the exercise trainings, and it should be long-term and always under the supervised control. But for today, adequate intensity of exercise training for these patients weren't established. While we can see that heart transplanted patients have the normal level of left ventricular ejection fraction, they have no heart transplant dysfunction. There are also different kind of causes why these patients still have physical exercise intolerance. And this could be cause of their heart failure, the duration of their cardiac disease, or there is an impact, especially in early term of cachexia, on the results that we can see during the exercise. Also, whether these patients were physically active prior to heart transplantation and chronic incompetence that we can see in 100% of cases after the surgery. But there are different kinds of benefits that patients face when they're physically active after transplantation. The long-term that helps for reduction in rest heart rate is the maximal success heart rate. So while in the beginning there is no heart rate variability, in more than 1 or 2 years we can see heart rate variability in patients who are physically active after surgery. Also, there is a benefit in increase in oxygen intake, improvement of their respiratory efficiency, and improvement in telephone function and others. For today, we can see that exercise-based cardiac rehabilitation was included for heart failure patients, and there are different kind of ways how they can exercise. But for heart transplanted ones, we still compare them with the healthy individuals and prescribe them the same exercise regimens that we have for healthy individuals. And these haven't changed even 5 years ago or during the recent guidelines that were published this year. This is my results. As we can see, in long-term patients who were physically active after heart transplantation, they really have a higher level of VO2 peak in long-term than those who still have sedentary lifestyle. But what has changed in CV rehabilitation during the COVID-19 era? It was around 1.5 years ago, it was May 2021, Marco Brazetti from Efficacious decided to create the special document how it can change during these difficult times. So as we can see, consensus was reached for continued referral to cardiac rehabilitation, no matter of COVID-19 era, and it should be applied for patients with chronic heart failure, heart transplantation, and in those who are long-term mechanical circulatory support. But it was decided that patients with chronic heart failure shouldn't be referred to the exercise-based center. If it's possible, you need to consent to rehabilitation for these patients because they are in the high risk. But heart transplanted patients should always be referred for cardiac rehabilitation, and especially exercise-based rehabilitation, no matter of history of COVID-19. So, which are appropriate referrals to cardiac rehabilitation, COVID-19 era? For chronic heart failure patients, the priority for class 3 or 4 could be considered, and for heart transplantation only in transplant heart center. It should be continued for long term. And this is our way how we deal with this problem, because patients couldn't go to the hospital, and my patients live in different cities and different places all over Russia. So we shoot the video, and they can download it at home and do some kind of simple exercise training, just not to stop moving. And the other part, when we talk about patients with chronic heart failure, those on intraop support, we miss the gap that after transplantation, these patients can go back to the normal sport activity, like going back to athletes. And this is the difference what we can see. It was compared during the 7-day Transalpine run, how can react to this physical activity for this long-term activity for heart transplant athlete or healthy control athlete. And we can see the big difference. But anyway, these guys went back to the end of this run and we're on 30th place there. And for all patients after heart transplantation, it should be recommended not only exercise-based cardiac rehabilitation program, but they also can be part of what was fun games. So it's not only about walking or jogging or going back to yoga. It can be really high intensity internal training for these patients. So in conclusion, there are a few parts. First of all, heart failure patients, we know that we need to prescribe them with a kind of exercise-based cardiac rehabilitation. But personalized approach to rehabilitation and tailoring the rehabilitation program, it should be according to patient's characteristics. And the main problem is financial feasibility in how to organize it during COVID-19 and due to poor adherence that we can face in different kinds of places. So this is the potential benefit and how we need to work on this in the future, especially to organize telemedicine for patients with chronic heart failure may have some benefit to and not to limit them for access to rehabilitation. And for heart transplantation, this is the last part. We need always to look for personalized approach and to prescribe rehabilitation for every of them. And we need to prescribe it for a lifelong rehabilitation. There are some benefits for their heart transplant function and for their going back to normal, going back to social activity. And we also need to find a way how to provide them during these difficult times. And in the end of my presentation, I want to show the benefit. When we try to work on rehabilitation in chronic heart failure patients who were on a drop support, who were in ICU, who were really severe, in the end of the day, after heart transplantation, these patients can go back to normal physical activity. And there are a lot of benefits that we need not to miss while talking about drug management or surgical treatment. Thank you.
Thank you very much, Maria. And we are moving on, and our next talk will be about remote monitoring. And it's my distinct pleasure to introduce our next speaker, Marat Fudim, who is advanced heart failure specialist and cardiologist and assistant professor from Duke University and Duke Clinical Research Institute, Durham, USA. Yes.
Collaborative space that try to develop and improve upon remote monitoring heart failure. So we heard from Yuri right in the first talk that we have made great strides in the application of guideline-directed medical therapy. Let's not forget, despite all the benefits we see with guideline-directed medical therapy, that the burden, the remaining burden of 2-year mortality and the heart failure hospitalization burden remain very high despite GDMT implantation. And this only applies to patients with HFrEF and totally excludes patients with HFrEF. So this is the typical scenario in medicine. It might be only true for me or my center. We tend to apply guideline-directed medical therapy. We titrate it up over a matter of weeks, months, years. And then we sort of wait and wait and wait in patients. And many patients remain in class 2 and 3 heart failure. And we often wait for them to deteriorate to the point or trigger through hospitalizations or reduction of medications, trigger to us something that indicates that we need to proceed to advanced heart failure therapies. And I think it is this gap of the wait and watch that can be filled or augmented with remote monitoring to try to get patients that are in class 3 heart failure down to 2 or 2 down to 1. And I don't think that medications alone can achieve that. While the primary goal for remote monitoring is to prevent heart failure hospitalizations, I do distinctly believe that that symptom burden can be improved independent of heart failure hospitalization reduction. While this is not as important of a goal to health systems or the government, I do think patients personally benefit the most by keeping them dry and improving symptoms in the outpatient setting. Here comes the problem. If we want to prevent hospitalizations or NYHA class 3 patients, and we simply rely on weight gain and symptoms as a surrogate of decompensation, impending outpatient worsening heart failure, we tend to be very late in the game. And you can see I didn't have a big budget to develop this figure, so this looks pretty cheap. But the message here is, if you want to identify patients in the process early, you need to look at more sensitive markers, and those markers tend to be device or biomarker based. Well, drawing biomarkers tends to be a lot more complicated than slapping on a device that measures impedance of the lungs or pressures in the heart, and training those patients using biomarkers or biometrics. You tend to identify patients a lot earlier, and then you can intervene and stop the impending decompensation. The paradigm that we got all ingrained, trained by our professors that are mostly gray-haired by now, is that volume overload and salt retention are the key drivers of cardiac decompensation, and that waiting for weight increase tends to be sufficient to prevent a cardiac decompensation. That tends not to be true, because what we see on the left side is that about 50% of patients present to a heart failure hospitalization without any significant weight gain. So 50% of patients had a weight gain of 2 pounds or more. The other 50% did not have any significant weight gain, as defined at 2 pounds or less. Look, the weight gain occurred in the preceding 7 to 10 days preceding hospitalization. If you look at pressures at the same time in the heart as measured, for example, with the Cardiomems device, this was not a Cardiomems device, however, you see that intracardiac pressure increase as measured by PA diastolic pressure, so that's wedge pressure, rises as early as 4 weeks prior to decompensation. So there's a disconnect. The pressure rises as early as 4 weeks, and weight, if at all it increases in the preceding 10 days. So there appears to be that volume retention or salt and water gain are neither necessary nor sufficient to explain cardiac decompensation in the majority of heart failure cases. So there's one good thing that came about from the COVID crisis, is that we not only have this conference online, but we had a telehealth transformation. The teletransformation occurred probably everywhere in the world. That remote monitoring clinics were started from one day to another, just out of necessity. And this is, for example, our telehealth visits that in our health system, it's 3 hospitals that were included. From 0 to 3,000 phone calls, clinic visits were generated within a matter of weeks. Same thing with video visits. And the thing is that those telehealth visits are not going to go away. They're going to go down a little bit once COVID is going to be gone, but we're never returning back to our old normal. So I believe, and so do many others, that the technology is no longer the limiting factor to do remote monitoring. The limitation that we see in remote monitoring, we have hundreds of approved devices in the United States alone. The limitation is really, how are we actually going to manage the data? Who's going to manage the data? That's this lady. And then how are we going to act on it? Are we having actually actionable alerts? And I think I'm going to try to give a little bit of insight into that. But at the end of the day, many of the centers need to figure it out for themselves, because remote monitoring really does not work as a cookie cutter approach. It tends to be personalized to individual providers, individual centers. So what is the evidence for remote monitoring? Well, non-invasive telemonitoring has a trend towards benefit. It is statistically significant if you pool all the data, even on all-cause mortality. The trend is a little bit less clear for invasive remote monitoring technologies for mortality, but certainly for hospitalizations, primarily driven by the Champion and the Guided Chapter study, we now know that we can reduce heart failure hospitalizations using invasive remote monitoring technologies. What is Cardiomems? I'm not sure it's available in Russia, certainly available in the United States now for several years. But it is an implantable remote monitoring technology which is placed into preferably the left pulmonary artery. It measures systolic, diastolic, and PA mean and diastolic pressures. We follow primarily the PA diastolic pressure because it's a surrogate of the wedge pressure. And we know from the Champion trial, which was a landmark trial for 2 reasons. First was the largest remote monitoring trial that showed a benefit on heart failure hospitalizations and the primary endpoint of combined heart failure hospitalization and CV death. And it also was the first and only trial beyond Emperor Preserve to show an improvement on heart failure hospitalizations in HFpEF patients, because there was a 20% HFpEF population in this trial. And this trial was published in 2011, but back then that was the first trial to show that any form of therapy or guided management would improve clinical outcomes in HFpEF. So this was technology number one. Another technology, and I'm a little bit biased because those are the technologies we use in my remote monitoring clinic, are the implantable devices. Every ICD to date has some form of heart failure remote monitoring, and Boston Scientific Heart Logic system is one of those. It tends to be one of the more developed ones. They actually have done some dedicated prospective development and testing studies, the so-called multi-sense study shown here, published in JACC-HF, where they have demonstrated that their sensor, which combines 5 separate sensor technologies, such as the heart sounds, S1 and S3, respiratory rate, thoracic impedance, and activity level. All of those combined using proprietary mechanisms derives you what is called the Heart Logic score. What the company decided on using the multi-sense trial is that if you hit this value of 16, it's a unitless value, if you hit 16 or greater, that you are at increased risk for heart failure hospitalization. And this was found to be present with a high sensitivity, with a low rate of false alerts, because false alerts can always happen, but the rate of false alerts was relatively low. And most importantly, and this is the key point of the entire talk probably, is that when you use any form of remote monitoring, but here specifically multi-sense, you are detecting decompensation events 34 days in median ahead of the actual hospitalization event. So when your alert crosses 16 and is greater, or your Cardiomems pressure is rising and going up rapidly, you have weeks time to act. Unlike when the weight goes up, because when the weight goes up, you do not have weeks left to prevent cardiac decompensation. So how powerful is the Heart Logic score specifically? Well, if you are in alert status, 16 or greater, versus not in alert status, your risk of hospitalization was 10 times greater. That's one way to visualize that. You can augment that with biomarkers. Nobody asks us to turn off our brains and rely on technology. If you are in alert status and you have an elevated NT-proBNP compared to out of alert status and a low NT-proBNP, now your risk is 50 times higher. So it is a very, very strong predictive marker, particularly when put into clinical context. So this is a case from my institution. We actually published upon that. This was a man that when we activated our remote monitoring clinic, he went from the white zone, this is below 16, into the gray zone above 16 of value. I called him around here and I talked to this man and I said, why, how you feeling? He said, I'm feeling fine. And he's the prime example why I don't like to transplant unmarried men. Why? He was luckily married. I asked to talk to his wife and his wife told me he's feeling miserable and he's just lying to me. So I asked him to see if a colleague of mine, and this patient ended up being hospitalized and transplanted. That's how sick he was, transplanted within 3 months of the initial phone call. You can see individual trend lines. You see the individual contributing parameters, those 5 parameters, which contribute individually to that score. Due to time, I won't go into this anymore, but this clinic where we essentially apply traffic light system. If you have an alert, your pressure goes up, your Heart Logic score is positive, we have a team member contact the patient, and in 50% of cases, we identify a problem. That problem is non-compliance with diet or water intake, non-compliance with medications. And just that alone tends to already resolve the problem. In the other 50%, we do recommend people either to take a blinded up titration of diuretics, or we use the opportunity to improve guideline-directed medical therapy. Each contact with the patient is an opportunity to improve GDMT. If the score subsequently is improving or the pressure on Cardiomems is subsequently dropping, we leave that patient alone. We no longer talk to the provider who is in charge of that patient. If that score is not improving, we will repeat this entire loop. And if that score is worsening, we force an in-person visit with the dedicated provider who's in charge of that patient, because I'm not always in charge of those patients. I'm merely the mitigator. All right, so what are the questions we need to solve at each individual center before embarking on remote monitoring technologies? This is what I tackled internally. Well, it's important to know who's going to be in charge of the data, how you're going to pay for that person, how are you going to communicate that data back, what technology you're going to settle on, and which technology you're starting with, and which patient you're going to start applying it to. Are you going to go for inpatients or are you going to for outpatients? I think once you address all those questions for yourself internally, you're good to embark on remote monitoring. I'm going to stop this with I have two more cases, and I will stop, and I'll show you two teaser cases for the upcoming discussion. Because what I would like also to communicate is, it sounds like I'm all excited about remote monitoring. I am, but it does not mean we have to turn off our brains. So this is a case of a Cardiomems implant. I implant Cardiomems in my cath lab, and I perform a blood volume analysis right then and there in the cath lab. So I measure the blood volume using a radioactive tracer. And that's performed at the same time in the cath lab. So this lady of mine who has hypertrophic cardiomyopathy, it's an apical variant. Think of it as a stiff HFpEF patient. She has a PA diastolic. The green line is the PA diastolic pressure. She has a PA diastolic of 18, 19 upon implant in the cath lab. At the same time, I measure blood volume, and I'm just going to help you read this. This is the total blood volume in the blood stream. So it's intravascular. She was minus 15% deficient. She was dry. And anything plus minus 10 is considered to be normal. So she was dry, but her pressure was 18, 19. So pressures do not equal volume. We all know that the primary response to Cardiomems, where the pressure is up, it tends to be diuretics. But we need to be careful that it's not always the right answer. So in this lady, we actually stopped the diuretics and were focusing more on vasodilators and maybe consider something like inotropes that would fit, but this didn't fit this clinical scenario. So it's really vasodilators in that case. Another case, it's a young lady with HFrEF. She had chemo-induced heart failure with reduced ejection fraction. She recovered from the acute insult of the cancer and it developed heart failure. We implanted Cardiomems, and she had a PA diastolic, again, on the table of 19, 18. Look what her blood volume was. It was deficient by 37%. Again, pressures do not equal volume. And this lady, again, we stopped the diuretics because diuresing her would have been the wrong answer. And I will stop here because I don't want to take too much time. We can go into this discussion if you like later. Bye-bye.
Many thanks for your talk. Yes, we certainly will have discussion at the end, but now we'll go further. I want to introduce the next speaker, Harriet Vance Pell. She's associate professor of medicine, researcher and cardiologist with clinical focus in heart failure and cardiology at McMaster University in Hamilton, Canada.
I am absolutely delighted to be here. Thank you for having me. And my friend, Dr. Soloviva, will advance my slides since I can't seem to project them for myself. I'm going to jump right into the second slide, which depicts the lifetime readmission risk after heart failure hospitalization. This data is from 300,000 patients in our province and plots readmission rates as a function of time from hospital discharge. And what you can see is that there are two phases of high risk following hospital discharge. The first high risk phase is the transition phase, which are the weeks following hospitalization, marked by about 30% risk of readmission. This is followed by a plateau phase in which patients face a 15% risk of readmission, followed by a terminal palliation and prioritization phase near the end of life, where about 50% of patients require hospitalization. These red periods depict those in which we can impact care, improve the patient's experience, and reduce the risk of readmission. Next slide, please. The tenets of reducing readmission and death after hospitalization for heart failure include, first and foremost, addressing the underlying causes of heart failure. And I won't go through all of the causes, you all know what they are. But this is absolutely essential in order to manage the patient with heart failure. A second aspect of care during admission is to decongest the patient. We know that residual congestion is an independent predictor of readmission, so freedom from congestion should be a goal. Now, how do we achieve that? Is rather unclear. We diurese patients. There's been no clear benefit from vasopressin antagonists, vasodilators, IV diuretic infusions, and even ultrafiltration. And patients often need some tailored approaches to optimizing their individual care. Common reasons for residual congestion: low cardiac output, dominant right-sided heart failure, advanced kidney disease, symptomatic hypotension, and limitations to patient self-engagement or care. Next slide, please. The Galactic Trial, the first Galactic Trial, tested our usual approach of aggressive vasodilation versus usual care in acute decompensated heart failure, and showed that an aggressive approach of maximal sustained vasodilation combining nitrates, hydralazine, ACE inhibitors, Arbs, or sacubitril valsartan did not improve the primary endpoint of all-cause death or heart failure rehospitalization at 6 months, compared to usual care, which entailed the normal use of pharmacotherapies that have been shown to improve heart failure outcomes. Next slide, please. And these 4 classes are plotted in this graph here, which reflects the Canadian guidelines. And I was pleased to sit on the committee for these guidelines. But we recommended, like other societies, that a strategy of simultaneous initiation be adopted over our historic tendency to sequentially introduce therapies, which were based on the historic way in which our trials tested the efficacy of various classes of medications. So we recommend the simultaneous titration or introduction and then slow titration up of Rnes, beta blockers, MRAs, or Sglt2 inhibitors. And based on access or intolerability, one might consider ACE or Arbs, which are effective, as opposed to Rnes. But we recommend Rnes as first-line agents. Keep in mind that LVEF is a continuum, despite our tendency to treat it in categories based on the way we recruited patients for trials, and that all of these classes have proven to be effective across the EF continuum, at least until an EF of about 50 to 55%. For RAS inhibitors, there's an additional sex treatment interaction so that women are more responsive to therapies at a bit of a higher EF range than men have been. Next slide, please. There have been newer classes of agents, specifically Sgc stimulators, cardiac myosin activators, that have been purported to be less effective due to the high-risk nature of patients enrolled in the Victoria and Galactic HF trials. I would argue that high-risk populations are best suited to showing treatment effect. The higher the risk or event rate, as you can see here on the x-axis, the greater the statistical power that enables an effective therapy to precisely show treatment effect. And here we have plotted absolute risk reduction on the y-axis versus event rates or risk on the x-axis. And as you can see, among all of the trials of heart failure, the higher the risk, the greater the effect, at least among effective therapies. And this provides an argument for the 4 classes of therapies that I discussed, because you see that ACE inhibitors, beta blockers, MRAs, and Rnes, as well as Sglt2 inhibitors, are all giving us more bang for our buck, greater absolute risk reduction for any level of risk, whereas some of these other agents, which are second-line agents, which have shown in some subgroups to be effective overall, despite large sample sizes, high event rates, have not really given us the treatment effect to justify their use as first-line agents. Next slide, please. The Pioneer trial tested the efficacy of sacubitril valsartan, next slide, please, in patients hospitalized for heart failure, and compared to enalapril at a dose of 10 milligrams twice a day, showed a greater reduction in NT-proBNP from baseline. Now, this is a surrogate outcome, but in safety endpoints, sacubitril valsartan was proven to be safe relative to enalapril among patients hospitalized for heart failure. Exploratory analyses also showed some reduction in clinical endpoints. Next slide, please. Another class of medication, I was going to say that there are 2 indications in which, next slide, please, 2 indications in which Rnes have not been proven efficacious over Arbs or ACE inhibitors among the hospitalized patients. The first is patients who have advanced heart failure. The LIFE trial, a small trial that was interrupted due to COVID, demonstrated that among patients with advanced heart failure who had recent hospitalizations, a strategy of sacubitril valsartan versus valsartan alone did not decrease the median NT-proBNP. And you can see that the NT-proBNP, in fact, increased in both groups, which speaks to the point beyond which therapies become ineffective. So really, the strategy should be early initiation of therapy early on in the disease course to prevent these late desperate attempts to improve outcomes when patients are near the end of life. This trial also showed a hint at greater risk of sacubitril valsartan versus valsartan among patients with advanced heart failure, greater hyperkalemia, a numeric increase in cardiovascular death or heart failure hospitalization. Next slide, please. Another patient population in which Rnes were not proven efficacious over ACE inhibitors was the Paradise MI trial of patients who were immediately post-MI. These patients were half a day to 7 days post-MI with other risk-enhancing characteristics such as reduced EF or pulmonary congestion. This trial showed that sacubitril valsartan reduced the composite primary endpoint of cardiovascular death or first heart failure hospitalization by about 10%. But there was not a statistically significant reduction. No increased risk, however. So in some patients who you anticipate will have persistent LV dysfunction or chronic heart failure, based on results of the Paradigm trial, you might still consider starting an ARNI, but keep in mind there was no statistically significant improvement. Next slide, please. The other class of agents that have been tested in the inpatient setting, of course, is the Sglt2 inhibitor. So Impulse, that was recently presented at AHA, demonstrated that among patients who were stabilized following hospitalization for heart failure, who did not have hemodynamic instability or requirements for IV vasodilators or changes in IV diuretics, and who had elevated NT-proBNPs, that a strategy of empagliflozin compared to placebo improved the primary composite endpoint of time to all-cause death, heart failure exacerbation frequency, time to heart failure exacerbation, and health status. So a beautiful primary endpoint that combined clinically relevant outcomes to patients and demonstrated that the win ratio, which is a specific analytic plan that compares patients in pairs versus the time to first composite outcome, demonstrates that there was a 36% improvement in this primary endpoint among patients who had received empagliflozin. Next slide, please. The Soloist heart failure trial also demonstrated that SGLT2, SGLT1 antagonists improve the endpoint of cardiovascular death or worsening heart failure among patients hospitalized for heart failure, driven, however, primarily by an improvement in heart failure hospitalization. So no improvement in death, unlike the Impulse trial. Next slide, please. The Affirm heart failure trial tested the efficacy of ferric carboxymaltose among deficiency, regardless of whether they had anemia. These patients were all hospitalized for acute heart failure, were clinically stabilized, and the primary outcome of total heart failure hospitalizations or cardiovascular death were reduced with a marginal statistical significance. So the risk reduction was in the range of 21% with a p-value of just over 0.05, but improvements in health status and quality of life. Next slide, please. So a strategy of IV iron is recommended in patients who are iron deficient and hospitalized for heart failure. Despite all of this high quality evidence, we see that in clinical settings, guideline-directed medical therapies underutilized with target doses of ACE inhibitors, Arbs, Rnes, and beta blockers uncommon after a year of hospitalization. Discontinuations that are marked here by red are also common among patients on ACE inhibitors, Arbs, beta blockers, MRAs, and Rnes. Next slide, please. A trepidation that clinicians often have is kidney disease. So all of these trials recruited patients with a GFR greater than 30. There were some trials, some of the SGLT2 inhibitor trials that used a threshold of 25. And it's important to note that in all patients, including those with kidney disease, outcomes improved with these classes of agents, particularly among patients who had diabetes. So we know in diabetics, ACEs, Arbs, SGLT2 inhibitors, and MRAs improve renal outcomes, cardiovascular outcomes, and yet we have this caution when we treat patients who have reductions in GFR. We accept drops in GFR of about 30%, next slide please, before we recommend changing direction in therapy. If you have a 30% increase, please review for other causes of kidney injury, correct the volume depletion, reassess medications that might be nephrotoxic. In hyperkalemia, you might consider diuretics or GI cation exchangers instead of stopping therapy. We know that reductions in GFR are common after these classes of agents are started. They do not correlate with renal outcomes. So you'll see an increase in creatinine persist because we know that patients actually improve renal outcomes despite the increase in creatinine. Next slide, please. The next strategy in improving outcomes is to assess risk. We showed that a simple 2-variable risk score predicts outcomes with as much accuracy and discrimination as complex risk models that require 25 to 30 variables and are impossible to calculate at the point of care. So just your length of hospital stay and the number of emergency department visits in the preceding 6 months predict readmissions and can be used to disseminate information to patients so that they know what their risk is and what the importance of adherence to medical therapies might be. And for some patients, it might guide them into end-of-life care planning. Next slide, please. Another tenet is to improve transitional care to make sure that your patients transition from hospital to home safely with adequate care supports. Next slide, please. We did a meta-analysis, a network meta-analysis of trials, and demonstrated that among a variety of strategies, disease management clinics, nurse case management, nurse home visits were more effective than telemonitoring, telephone support, pharmacist interventions at reducing all-cause mortality and all-cause readmission. Next slide, please. We combined these effective strategies into a model of care that we introduced in our healthcare system and tested using a stepped wedge cluster randomized design. Next slide, please. And we demonstrated that unlike these explanatory trials in which these interventions improved endpoints, in our real-world clinical care settings of older adults with language and communication deficiencies, cognitive impairment, complex socioeconomic status barriers, that we were unable to improve the composite endpoints of all-cause readmission, emergency department visits, or death at 3 months or 30 days, but we were able to demonstrate a significant reduction in all-cause emergency department visits. We also found that the primary endpoints improved in women, but not in men, and it may speak to the inadequate social supports that women have when they are faced with heart failure. They're typically predeceased by their spouses, and it may be that they derive greater benefit from these supportive transitional care measures. Next slide, please. We found that these measures, while they didn't improve the primary composite endpoint in all patients, improved health status and improved the patient's perception of quality of care, as well as their preparedness to take care of their health status. Next slide, please. And as I mentioned, we showed that there was a sex treatment interactions where females derived a significant 20% benefit from these interventions. Next slide, please. Transitional care includes palliative care. Do not forget the use of ambulatory palliative care services. We showed among 400,000 patients who died of heart failure, a majority still die in hospital, contrary to their wishes. Death in hospital is associated with a 2-fold to 3-fold increased cost, and the use of futile invasive care strategies that do not actually improve outcomes and that are often discordant with the wishes of patients. Next slide, please. The use of ambulatory care palliative services was associated with about 30% decreased odds of dying in the hospital, and is something we all need to consider for our patients who are at the end of life. Next slide, please. Another important aspect is to address cardiac and non-cardiac comorbidities, which are common causes of readmission following heart failure hospitalization. Non-cardiac comorbidities such as respiratory infections, COPD, and kidney disease are common and should be addressed, particularly in the COVID era with your flu vaccination, COVID vaccination, and other interventions to improve non-cardiac care. Next slide, please. So In summary, strategies to improve outcomes following heart failure hospitalization. First and foremost, optimize medications, communicate prognosis, organize transitional care services, address comorbidities, both cardiac and non-cardiac. And I have it twice apparently in this graphic because it is important for us not to just care for patients' hearts, but to care for them in a comprehensive manner, keeping in mind that half of all patients are readmitted due to non-heart failure causes, and that the admissions for non-cardiac causes increases as the LVEF of the patient increases, which speaks to the importance of integrated care. Thank you so much for having me. I'm delighted to take your questions at the end.
And I'd like to kick off with the first question for Professor van Spaal. So you mentioned that this is a very sensitive phase immediately after discharge. And given the fact that most or a lot of the people, like 40%, are still congested when they are discharged. So do you systematically screen for the volume status, and how do you do it? It's a very practical question.
Yeah, we have shown that patients are commonly inadequately decongested at the time of hospital discharge. You know, there has not been great clinical trial evidence with regards to what services specifically improve outcomes. So there are some services that hospitals provide where patients can continue to receive IV therapies at home, come into day ambulatory units, have these hospital at home units to continue decongestion. And we have some sense that these home programs can improve readmission rates, but how to adequately decongest patients during admission, you know, it's sort of, sometimes you have to try different strategies, and in some patients, IV infusions are more effective than the twice or thrice daily boluses that we are used to seeing. There are certain criteria that patients should meet prior to discharge. So inadequate congestion is a red flag. Really, you want patients to be free from signs of volume overload and to be able to walk without symptoms. You want to see a reduction, and you know, there's been varying evidence about how much of that reduction in NT-proBNP should be seen prior to discharge. You don't want the creatinine to be on the rise prior to discharge. This is another sort of red flag, an adverse prognosticator. And then, of course, making sure that the patient is able to understand and adhere to therapies and have no socioeconomic barriers with regards to accessing therapies. So they might be adequately decongested in the hospital, but not be able to access therapies to keep them euvolemic in the post-discharge phase. So it's a matter of addressing the hemodynamics, the physiology, initiating appropriate therapies, making sure they transition to some home care services if ongoing diuresis or is needed, particularly near the end of life when they become refractory to strategies to bring about euvolemia, and then ensuring that there's affordability and access to therapies to keep them stable.
Excellent. Thank you so much for your comprehensive answer. Do we have any questions from the chat already, Yuri?
Yes. We have a question for Bogdan. What about left atrium volume? Will be some value of this whole volume will be in which left atrium volume you wouldn't take patient to ablation?
Thanks for the question. We have good data, we have meta-analyses and so on, and we know that left atrial diameter or volume, either through echo or through CT, from CT scans. So the bigger the left atrium, the higher the lower of success rate in AF ablation. As to a certain threshold hold to not even trying ablation. I don't know. I think it depends a lot on the age of the patient. It depends on the symptoms. It depends on for how long has this patient been in AF. I think it's a individualized decision between the patient and their caretakers.
Okay, and one more question. If patient have very big left atrium, would you prefer endoscopic ablation or send to surgeon for terracoscopic ablation?
So I'm not convinced. I'm not convinced by sending patients to surgical AF ablation just for this. So of course, if they need bypass CABG surgery or so on, of course. But just for AF ablation, I think it's a bit hard. And speaking of the strength of the evidence for mortality benefits, I wouldn't go that far to have an invasive procedure.
Okay, thanks.
I do have another question. The age of the patient and the BMI can also be used to guide the decision to ablate. We use a 140, 145 cc threshold based on observational data to show that that threshold predicts recurrent AF, but I'm not sure what others do. There's probably some variation across centers based on expertise and the tolerability of having somebody come in for a reablation, I think.
Great point. I do have another question for Mara. So you showed all these new technologies, Cardiomems and the hard logic, and I feel that there are a lot of data coming in due to these novel devices that are unused. And you mentioned briefly the role of data management, how important it is for decision support tools. So do you use artificial intelligence or machine learning algorithms to incorporate all the data and making sense out of these data?
Don't help anybody. It's just you use wasted money and time to generate data if you don't act on it. So I think having in place structures that can act on the data is very important. Having actionable data is very important. You can have the fanciest sensor if you don't know what that means or what to do upon that is going to be worthless as well. So I think that's why pre-planning, that's why I had that second last slide or third last slide to show that the pre-planning is important before you go into the remote monitoring clinic endeavor. At the same time point, there are solutions being crafted by individual companies and trial structures to try to identify if A happens, B should happen. The problem is just showed you, that's why I had those last two slides. I don't want to say too loud because I think this is recorded, but certain trials might not be always favorable if we have a one-dimensional assessment of congestion. I'm writing a congestion paper right now, and I must say, I don't even know how to find congestion. Is this a pressure-based, is it a volume-based assessment? Is this IVC? Is this lung volume? You don't know because it means different things for different patients. So I think I'm a believer that a multi-sensor approach, whatever those are, tends to be superior to a uni-sensor approach because it tends to be better in the detection of the true nature of congestion. Here comes the problem, is that it's sometimes harder to act on multi-sensors than on the uni-sensor. But, I probably didn't answer it properly, but there's more to come. We don't know. We lack strategies. Yes.
Perfect. So Professor van Spaal would like to comment on it, right?
Yeah, so we use machine learning in our data sets, and these are great when you have large volume, multidimensional data. If I had to critique the strategy, it would be to say that a lot of our machine learning algorithms are great at predicting risk. But many of these algorithms haven't been externally validated in larger cohorts of people across ranges of risk. That's one issue. The second issue is what to actually do about that risk, right? It needs to be tested in the context of a randomized clinical trial, in absence of which we are all just shooting in the dark, thinking that we are acting upon alerts, but not really knowing whether our strategies are effective or not. And we've seen time and time again that physiologic markers, indices, things we think are a for sure bet don't necessarily prove to be effective when we subject them to the rigor of a randomized clinical trial. So I would say lots of potential with AI. We have shown, for example, that phenotypes based on simple comorbidities in patients hospitalized for heart failure more potently predict risk with greater discrimination than EF categories. But what do we actually do about it? We know that COPD patients who are admitted with heart failure, regardless of EF, are at the highest risk of hospitalization or death. But is there any strategy specific to that group? That needs to be tested. The sleep apnea population is another high-risk population, but we know that treating sleep apnea doesn't necessarily improve outcomes. So there's one thing about risk stratifying patients, flagging patients who are at risk of decompensation, but what to actually do about it, we have knowledge gaps to traverse.
Absolutely great comment. Totally agree, and lots to learn from these new technologies and devices. I think there's another comment from Bogdan.
Yeah, it's more of a question for Marat. How do you, in your practice, how do you deal with the potential danger? At least I see it as a potential danger of siloing all these sensors and all this remote monitoring between blood pressure, heart failure, the sensors you've been talking about, cardiac devices going into EP, and I don't know, just the random Apple Watch or AliveCore Cardia and so on. Is it by subspecialty? Do you try to keep it all together around the patient? What do you do?
So it's a good point. Of course, now for some reason, we started off with EP owning a lot of the remote monitoring because that was the implantable technologies. I personally believe, since the heart failure care is in the hands of heart failure providers, that remote monitoring needs to slowly move back to the heart failure cardiologist. And that's true already for monitoring Cardiomems and HeartLogic technologies, Optival technology. I think it's slowly moving to the heart failure space, but we'll never keep up with the pace of remote monitoring, particularly when it's about scales and cuffs that can be remote. In Germany, they have proposed that individual providers are not allowed to be monitoring patients remotely and bill for it. It needs to be happening centralized facilities. So in the perfect world, all remote monitoring is centered, at least an individual center, at one provider's hand or in a region and one provider's team. Without doubt, it would be ideal. The problem with that is that care doesn't work like that, because if you centralize remote monitoring in my hands and I have to supervise 200 cardiologists in my region, how am I going to be able to effectively apply the actions that need to happen? So this is something we're figuring out for ourselves. It might be, we have difficulties in large centers. You don't have difficulties like that in small centers. And so there's no perfect answer to what you're saying, but we certainly in our center trying to centralize care for all remote monitoring technologies. But it's like the Roman Empire. At some point you will grow too big and then you will fall apart. But we're not there yet.
Angela.
Yeah, maybe another question again to Marat. You showed us the case of hypertrophic cardiomyopathy patient, and I think it's very important for our listeners to highlight the discrepancies between volume status and the pressure-based metrics of congestion. And could you please just tell us about this? And one question is why your strategy was based on vasodilation, because it's quite, if the ejection fraction was supranormal, especially, we could expect maybe a drop of blood pressure, etc., some complications from this strategy. Maybe it's just need to just add more water to the patient.
Yes, so I think 2 points. So first of all, in that patient, we of course stopped the diuretics first, and if pressure to increase any further in the future, we would have attempted preferentially to use vasodilators as opposed to diuretics, because there's really no more volume to give. But we actually ended up running her a little bit dry. She was not anemic, so that was not a target either. What I didn't show you is that we already have that in under review. We actually did that not in just 1 or 2 or 3 patients. We did it actually in the dozens of patients across a couple of centers, because we wanted to show that the concept of volume does not equal pressure is not new. It's an old concept. But I'm bringing it to the modern ages of cardiomems, and I'm saying, listen, I'm managing cardiomems. I'm a fan. The problem is that if we use only one dimension, we turn our brain off, and we follow the lines, and in the management, so, oh, pressure's up, we need to give diuretics first. That might actually not work. So we need to be a little bit cognizant about what happens with the volume as well, which is the other dimension. The correlation with the pressure and volume was 0. There was no correlation between pressure and volume in all of those patients that we measured. Elevated pressure versus elevated volume. It was not happening. And as a matter of fact, 70+% of patients were having an elevated pressure, greater 15 of a wedge, but had a decreased or normal volume. So diuretics would have been, in 70% of patients, the wrong answer if you would want to start that as the first agent. So I'm not providing solutions. I'm just telling you that diuretics might not be the first line in all of those patients. You might want to try vasodilators or inotropes. I had patients where and I think that applies, for example, for patients that tend to already run dry and they have a high pressure. You cannot improve the high pressures by just removing volume. You might actually have to give inotropic support to, so they're dry and cold in that regard. And inotropes are the solution. The only problem is pressure-based technologies give us the one dimension of that, right? We don't know if they're actually cold, and then we don't know if they're actually wet or not either.
And that's really important because in Champion-HF, for example, the diuretics and nitrates were the two drugs which were the doses of which were changed mainly. So it's
Correct.
a really good point. Yeah. We have a question from chat, and Maria, I kindly ask you to answer for our listener. The question is, if a patient has not any sign of right-sided heart failure, no edema, no changes of echo regarding to congestion, but the patient has decreased, mildly reduced ejection fraction, should we initiate the diuretic therapy, and particularly spironolactone or eplerenone? So patient without clinical congestion, without echo signs of congestion, but with reduced ejection fraction, would you start MRA?
Possibly, yeah. But I mean, yeah, possibly, yeah, we can start it, but we need a little bit more data about the patient. I mean, this is about clinical assessment.
So
I would
no
say
data.
also, if I may add, that trials have typically used NYHA class to recruit patients versus volume status, right? And so we know that MRAs have a role in heart failure with reduced ejection fraction in patients who are symptomatic. I'm just going to throw in there something that we haven't discussed, which is how to best assess a patient's symptoms. And we traditionally use NYHA class, and we have lots of evidence now that having patients report their own symptoms is much more sensitive and accurate, and also associated with clinical outcomes. So self-assessment of symptoms using a health status scale, we are used to the KCCQE. There's now a shortened 12-item KCCQ scale that can be used to really ensure that our patients are asymptomatic. Oftentimes, who we deem to be NYHA1 is not really NYHA1. They have just compensated and adjusted their activity to stay asymptomatic. But when patients self-report, you are able to engage in discussion about how to optimize therapies. And as one of the recent, the CHIEF trial showed, recruiting patients based on the health status, threshold of 80 in the KCCQ scale can effectively result in an intervention that shows an improvement in their symptoms. So, I'm not sure that volume needs to be considered to start these therapies at all. Volume needs to be considered in starting a loop diuretic, for example. But an MRA, I would offer a patient who's symptomatic with reduced EF an MRA. And it speaks to Maria, right? The bit of a variation around what we all do. There is a bit of variation. And I think some of it comes from the way trials recruited people, what their criteria were. What do you think, Yuri or Marat? I don't know.
I mean, in addition, there are patients still with restrictive cardiomyopathy. Also, some of patients can be considered for heart transplantation with left ventricular ejection fraction around 40. But there is no way for hospitalization in these patients, and they be considered only because of their progression of IHD. But on the other way, we have patients with dilated cardiomyopathy with left ventricular ejection fraction around 17, but the VO2 peak is going to be around 30. So this patient is not for heart transplantation. So it's always about the clinical assessment, and it's also about what drug management we can use in the particular patient, and self-report also is important. But all this clinical assessment, examination, we need always to have the whole mix to understand what's going to be better for the particular individual.
Maybe just to make a discussion more. So we are talking about clinical congestion and the symptoms, and we discussed the early initiation of the medical therapy and perhaps maybe ablation also. Do you think we really need to wait for the severe symptoms before initiation, for example, sacubitril valsartan? Because in Russia we have from this year indication for this for Rnes, like arterial hypertension. I think it can be controversial, but perhaps it may reduce risks of heart failure development as well. So what are your thoughts on that?
Well, I can kick that off. So first of all, as to clinical congestion, I think Harry had made a great point that we don't know. The trials, Efficacious, and RALs, used for MRA symptomatic patients to enroll them. But we probably know that you don't have to have symptoms, even structural changes alone might actually predict already heightened risk. And we know that that's where it's going. You're just catching it early. I tend to initiate medications with a discussion of risk before symptoms occur if I see structural changes. That's particularly true if patients are younger. And as to Rnes, so I don't know that we have an indication in the United States for hypertension for Rnes, but certainly it has been expanded to systolic dysfunction. So you can have an ejection fraction of 55 and technically be initiated on it. So I use usually 50 as a cutoff. If you come close to 50, I would initiate Rnes, even in asymptomatic patients. But for me, the major criterion is I want to see them a little bit younger. If you are young and you have an ejection fraction of 50, 51, 52%, that is not normal. I will initiate Rnes. I'll initiate anything I can and treat you like a half-ref patient. So I think my threshold over the years has been moving up and up and up, and asymptomatic is not a problem for me anymore.
Marat, may I ask a question? Would you do it even in patients who have a low BNP level, better?
Normal biomarkers? Yes. Yeah, I mean, I care about structural change. I need one hit. So heart failure is like a multiple hit model, like cancer, 2-hit model. If you have one hit and your structure's abnormal, if I'm in your clinic, I'm 25 years old. I'm just kidding. I'm not 25 years old. But if I'm in your clinic and I'm 25 years old and you don't start MRA Rnes on me with an ejection fraction of 50, I have a problem with you because, it's going to get worse. It's just a matter of time. And of course, control all the risk factors, etc. But I think we need to not treat pre-symptomatic patients like they're healthy.
If I could add that we have not, we had time restrictions at our talks and we didn't get into lifestyle, particularly for patients who have a normal EF and who have an elevated BMI. We must give pause to consider the role of other interventions that improve health status, walk distance, quality of life, that haven't been tested in large trials like our pharmacotherapies to show reductions in clinical endpoints. I will say there's a role for cardiac rehab and exercise therapy, caloric nutrition restriction in patients who are obese. And then for patients with atrial fibrillation, exercise and alcohol cessation have also proven to be effective at reducing the burden of atrial fibrillation. So let's not forget some of those modifiable risk factors. And then with regards to your question about Rnes, waiting till a patient is severely symptomatic, as we have seen from the LIFE trial, is often too little too late. So I would initiate therapies earlier on in the disease phase, with severe significant reduction in EF. You could argue that nobody's truly asymptomatic. You can test their symptoms on a treadmill or walk test, and initiate therapies as the clinical trials did, right? You didn't need a lot of symptoms. You needed NYHA class 2. That's a bit of shortness of breath on a bit of exertion. So I would err on the side of early initiation, evidence-informed therapies. Keep in mind that the risk reduction shown in clinical trials pertains to the type of people that were in clinical trials. So we would, in somebody who's asymptomatic with a, near normal EF on a population basis, you wouldn't get the degree of risk reduction that you see in the trials that, included patients with mildly reduced EF. But we also have to be pragmatic and think about, how do we tackle disease burden? Is it waiting for somebody whose EF is 50 to decline to 40? Why do that?
Perfect. Well, I think this is a great way and a great statement to finish this outstanding session, because we are running late already. So I'd like to take the opportunity to express my gratitude to our esteemed faculty for the great talk, for the great discussion. I really appreciate that, and we really appreciate that. So thanks again for your time and efforts. Also a huge thank you to my co-chairs, Yuri and Angela. It was my distinct pleasure to join you here. So be safe, take care, and enjoy the rest of the Congress, and hope to see you soon again in person.
Thank you for having me.
Much.
Thank you.
Thank you so much. Bye-bye.
Thanks. Bye.
Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии Общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии Общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии